Thank you for joining us this morning for today's Intermountain COVID Community Update, which is being streamed on the Intermountain Facebook page. We appreciate your time. I'm Jess Gomez from Intermountain Healthcare, and I'm pleased to be joined this morning by three of our physician leaders who will be providing updates today on how our hospitals and caregivers continue to be affected by the COVID pandemic. They're going to talk a little bit about the steps being taken to continue to provide high quality care for patients, how we're doing that within the Intermountain system and specifically at several of our hospitals, and some updates on the COVID vaccine boosters and guidance from the CDC and FDA. There's a lot of new developments. Joining us today is Dr. Eddie Astenim, Intermountain Healthcare infectious disease physician. Good morning, Eddie.
Good morning, Jess.
Dr. Adam Bergeson, an orthopedic surgeon and medical director of surgical services at Intermountain, Utah Valley Hospital in Provo. Good morning, Dr. Bergeson.
Morning, Jess.
And Dr. Edward Prince, an orthopedic surgeon and medical director of surgical services at Intermountain St. George Regional Hospital in St. George. And we're going to be talking specifically about how we are impacted at some of our larger COVID hub hospitals, such as Utah Valley Hospital, Intermountain Medical Center, and Intermountain St. George Regional Hospital. Before we begin, let me just do a quick recap of the data that we have. Yesterday, the Department of Health reported 2,340 new COVID cases, which included 800 cases from earlier in the week, 12 new deaths, and 59 new hospitalizations. Of those 2,340 new cases, 514 were in school-age children with a 7-day average positivity rate of around 15.7%. The Utah Department of Health is reporting 552 COVID-19 patients currently being hospitalized in the state of Utah. 196 of those patients are reported in ICUs and at referral centers where most COVID patients are being treated, and the ones that we're going to be talking about specifically today, the ICU beds are at 98.6% occupied, according to the Department of Health. So with that lead into that, let's begin with Dr. Astenim. And Eddie, why don't you give us an update as to kind of where we are and what that data says to you?
Yeah, thanks, Jess. So across our system, when we look at our ICUs, we're still at max capacity. So as of this morning, we're at 100% max capacity right now in our COVID ICU hubs. When we look at all of our ICUs, we're at 98% capacity. And so we are still chocked full with COVID-19 patients, which is making our capacity to be really, really strained. When we look at our state level data, what we're seeing is that we're really at a high plateau of cases. We peaked, we came down a little bit, and we're not seeing that rapid drop off that we had hoped to see. What we expect to see moving forward in the next month and a half, what we hope to see is a continued slow decline of cases. And so right now we really are plateaued, very slight decline, but really at a high plateau of cases. We are seeing some signals in the emergency department with cases of people coming in with what's called COVID-like illness, or people coming in with fever and cough. That syndrome is starting to abate a bit. So we're seeing a decrease in that, which may be an indicator that we're going to start seeing cases come down here in the next couple weeks. That's many times a nice leading indicator of what's to come. But right now, I think we're in a period of stability where our hospitals are completely full, our ICUs are at max capacity, and we're still seeing very significant number of cases of COVID across our system. When you look at the patients with COVID in our hospitals, the majority are still unvaccinated or not fully vaccinated. So between 80 and 90%, depends on the day that you look, of all those people with COVID-19 illness in our hospitals, 80 to 90% of them are unvaccinated, with about 10 to 20% of them being fully vaccinated. Again, there's some variability in that data. When you dig in further to that data and you look and say, what do the patients look like that are fully vaccinated that come in with COVID? Well, those patients are significantly older. And generally, it's approximately 20 years older than those people that come in with COVID that are unvaccinated. And they also have lots of medical comorbidities as compared to those that are coming in with unvaccinated. So just an example, the average age of the unvaccinated person in our hospitals is 50. The average age of those that are vaccinated in our hospitals with COVID-19 is 70. And so they're two very different populations. The people that are failing the vaccine, that are being admitted to our hospitals, those people are older, have more medical comorbidities. Those are the people that typically fail vaccines in general. And so it's not unexpected for us to see that, Jess.
Thank you. Dr. Bergeson, how about your perspective of what you're seeing there in Provo at Intermountain Utah Valley Hospital?
Sure. So we're seeing very much what was said, a sustained level of COVID patients and a sustained level of high census numbers, both in the ICUs as well as on the med-surg floors. The ICUs are near capacity every day. The med-surg floors kind of range between an 80 and 95% capacity. And obviously, we're very proud of our teams that have risen to the challenge of this increased volume. Our critical care teams have done a great job of adapting. We've been able to add a few ICU level care beds in the last couple of weeks. We've had some reinforcement of staff. Our med-surg teams are also have risen to the challenge and are doing a great job of caring for this increased volume of patients.
Thank you. And Dr. Prince, in St. George, you guys have had a sustained high volumes for some period now. What's the latest that you're seeing that you may report on what's happening there?
Yeah, St. George has been a little bit higher volumes. Our ICU has not only been full, we've been over full. We've expanded our ICU into our cardiovascular unit. So our normal number of beds is 32, but we've been typically seeing 37 to 42 ICU patients. Most of these are COVID. We got to one point where we only had 3 or 4 ventilators left in the ICU, and we decided maybe we needed to shut off some of our transfers. That has decreased our volume a little bit. Our hospital volume also has been near 100% on any given day. So in the morning, we might have 3 or 4 beds, but by afternoon, that's completely full, and we're having to turn those beds over as quickly as possible. This has been particularly hard for specialties that require ICU admissions, cardiothoracic surgery, vascular surgery, and some of our neurosurgeons have had to cancel multiple cases in the last several months. This has been tough on the community because sometimes some of these life-saving procedures aren't being done. I've heard of one instance where a heart simple bypass was delayed because of COVID, and the patient ended up passing away because of that. So we've seen a lot of very significant constraints.
What's your experience with your colleagues there in St. George, Dr. Prince? And sounds like you have been dealing with high volumes for a long time now. What's the environment feel like when you're feeling that constraint as you are?
Well, we went on restrictions of all elective inpatient cases about 8 weeks ago now. So this has been very difficult for some of these specialties who are trying to provide the best care they can for the patient, and we just can't because of this level. The other really tough thing that we've seen is there's a lot of burnout amongst staff, both physicians and nursing staff. And sometimes our capacity issues are not bed capacity, but it's staff capacity. We don't have enough nurses to take care of a lot of these patients. On any given day, we might have 10 to 15 nurse shortages. And so they're being expected to take more than their normal workload. It's high stress, and there's a lot of burnout, honestly.
Yeah, thank you. Dr. Stenium, in terms of heading into the fall and winter, do we have any better idea of a model or projections? Is it just we're holding on as best we can? What are you hearing about in the coming months and days that you're hearing from the ID community?
Right. I mean, I think we need to recognize that we're in a very different situation now going into the fall and winter compared to where we were last year. Last year we were coming into the fall, coming into the holiday season. We didn't have vaccines. We didn't have this, incredible tool in order to prevent infection and severe disease. Now we're moving in to the holiday season with vaccinations widely available and a very, very effective vaccine. In addition, we have to also reflect on the fact that well over 60% of those that are eligible have been fully vaccinated in the state of Utah. And there's a host of other people that have been infected and have some level of protection as well. And so we're moving into the fall, into the winter with a population that is less susceptible to severe disease as compared to previously. And so the projections that we have, take that into account. What proportion of the population is actually susceptible to severe disease? Those are the people that haven't been vaccinated and haven't had previous disease as well. And so that pool is significantly smaller. There's still plenty of people at risk. Case in point, our hospitals are full, primarily with unvaccinated individuals. And so there's still going to be people getting sick. What we hope to see is a slow decline as we move into the winter season. And then I do suspect that we will see some bumps along the way as people gather for holidays, which is a perfect time to transmit respiratory viruses as you're eating, as you're gathering with families in close quarters. But we really hope that we don't see those big spikes that we saw last year around this time. And we hope that we can, empty out our hospital a bit before we get into that period. And so that's our best guess. These are based on models and our community currently. And so we certainly hope that that's going to be the case. Continued vaccination, continued boosters is going to be the way that we can really minimize the suffering that we have as we move through the winter months.
As we have Halloween and then the other holidays coming up, what's the guidance? We're hearing people ask, what should I do, whether you've been vaccinated or not? What's the general guidance that you would offer?
Right. I think we can't forget that we are in the middle of a global pandemic of a respiratory virus. Our hospitals are full. We have to take precautions to prevent transmission. And we know what works for this virus. Masking works, social distancing works, vaccination works. And so if you are gathering, if you're getting together in close quarters, masking is incredibly appropriate still. And we highly encourage people to mask. We highly encourage people to not congregate in really dense indoor settings, especially when you have people that are at high risk due to age or due to complicating medical conditions, like cancers and the like. And so we can't lose focus on that. And we have to move into these holiday seasons cautiously. We know Halloween, we had a significant increase in infections last year after Halloween when we had some pretty significant gatherings, particularly in the younger age group. But fortunately, Halloween is pretty much outside. What I worry about with Halloween is gathering with families before going out trick-or-treating outside. That's when you're going to get transmission. And so as we move into Halloween, it's really important. Let's keep our kids, our families outside. We know that the risk of transmission is lower when we're outside, and we can have a safer time with our friends and family.
Thank you. Dr. Prince and Dr. Bergeson, on September 15th, Intermountain announced that they were postponing some elective non-emergent cases to help reduce some of the inpatient volumes at the hospitals in relation to the surge and the high volumes. Can you give us an update? Those are two areas within your specialties. What are you seeing with those delayed or postponed non-emergent cases? How are those going? What are you hearing from the community? And how are they impacting? Is that having a positive impact on admissions? Dr. Bergeson, let's start with you.
Okay. So as you mentioned, we began these restrictions back in September. We have continued to proceed with some surgeries. So outpatient surgeries were not affected. Outpatient surgeries are those where the patients go home the same day. We're continuing with those. Certainly urgent surgeries are proceeding, and we're providing that care basically as we normally would. The surgeries that are primarily affected are those that are non-urgent, requiring an overnight stay. And we have tried to move some of those to kind of a same-day discharge scenario. We've kind of reinforced protocols for hysterectomies and total joints being two examples where we can send patients home same day. We've allocated resources to that to try to continue to provide surgical care to these patients. Currently, we're at about 75% of our normal surgical volumes compared to where we would normally be. So these restrictions have impacted people. And the difficult thing is that these patients that require surgical care requiring an overnight stay, their quality of life is being impacted by the delay in care. Most people are pretty understanding of the situation. We try to communicate frequently with them regarding the potential, timing of surgery, but unfortunately, we just don't know when we're going to be able to provide the desired level of care. So there is some uncertainty. I think there is some frustration that's growing regarding the uncertainty, but there's not a lot we can do to mitigate that. So frequent communication and updates, and we're trying to provide at least a week in advance guidance for surgery schedulers and surgery teams so that they can best plan for what's ahead. But we're doing the best we can, and really we're trying to provide surgical care to as many patients as we can. But unfortunately, right now we're just limited. And I think we're trying to certainly express understanding that while the resources have shifted toward this critically ill segment of our population, we understand that these people still need care and require care. Their condition, surgical care is indicated, and they have real problems that we want to address. And there's just not room in the inn right now. So balancing the priorities has been tricky, and we're doing the best we can.
Thank you. Dr. Prince, same question for you in St. George with the restrictions there. What's the impact? What are you hearing? How are you guys doing with those?
This kind of varies based on service line. If you look at orthopedics, my specialty, for example, they've really adapted quite well and developed a whole program towards outpatient total joints. Hip replacements, knee replacements, which used to stay 2 or 3 days, now go home same day. And with the setup that we have and the various programs that we've instituted, we've shown that that's been safe and effective. Some of the service lines are affected more than others, particularly cardiovascular surgery, which usually requires a ICU stay. Heavy impact there. They've had to delay multiple bypass procedures, heart valve procedures, simply because there's not a room. I worry about those because these are life-saving procedures that we're missing out on. Vascular surgery, for example, a carotid endarterectomy, you can live okay for a while with an 80% occlusion, but the higher that occlusion gets, the more likely your risk of stroke is. So you can put those off for a while, but not forever. For example, a neurosurgeon doing a pituitary tumor, it's not an immediate need, that's more of an elective case for a while, but there's a time limit on that. Eventually, you're going to run into a point where that does become an emergent case. Another example one of our neurosurgeons gave is he said, I had a patient come in, they had an acute disc herniation with a foot drop. That doesn't have to go tomorrow, doesn't have to go the next day. Patient's certainly very uncomfortable, and we can delay that for a while. But once you get to 2 months, 3 months, now you're going to see significant adverse effects by not doing that case. And so this now transitions from an elective case to more of an urgent case. And we've been going long enough that we're starting to reach that time point. And so we may start to see significant adverse outcomes with patients if this doesn't change and we get some capacity in the hospital.
With that experience, what is your message to the community to understand that this is an impact that's far beyond select people, but it's really the whole population who needs care?
Well, I think the data is pretty clear that the majority of patients coming in the hospital are unvaccinated patients. I think, there's a lot of political stuff going on and a lot of decision making, and everyone has their own choice. Number one, I would say make your own decision, make what's a good decision for you. But number two, start to think about the community as a whole. Think about your grandmother, your relative who might need one of these procedures and can't get it done because of your negative opinion about the vaccine. Just get it. I've had the vaccine. Many of my colleagues have had the vaccine. I feel that it's safe, and that's why I did it. But I think there's also a broader look at what we can do for the community as a whole. these people could be helping out their grandmother or their healthcare provider. And if we don't do something to change, we may lose a lot of these providers and make the situation even worse. So get the vaccine.
Thank you. Dr. Stidham, we have had some questions about some of the developments that are occurring with on the vaccine front, including the boosters. Wondered if you could give us an update on where the CDC is going and what that means for the community in terms of the next step for booster shots, including Moderna and J&J. Can you give us a broad overview of where we are with that?
Sure. It's certainly getting complicated, isn't it? So ACIP, which is the Independent Advisory Council for the CDC, met and gave recommendations yesterday regarding booster shots for both Moderna and J&J. And so now we have recommendations for booster shots for Pfizer, Moderna, and J&J. And those recommendations are now very similar across the board. If you've had either Moderna or Pfizer, the primary series, and you're 6 months out from your last shot, you're eligible for a booster if you're 65 years of age or greater, or if you're between 18 and 65 years of age, and you have a complicated medical condition. This could be obesity, this could be diabetes, really just about any complicated medical condition, or you live or work in a place where you're potentially exposed to COVID-19 much more than the average person. So healthcare workers, for example, teachers, is another example. Those people are eligible for a booster if they're 6 months out from both Pfizer or Moderna. The J&J booster is a bit different in that if you are 2 months out from your J&J original shot, you're eligible for a vaccine just if you're 18 years of age or older. So think about a J&J booster as just really the second shot in the series. We suspect that J&J will be a 2-shot vaccine regimen, just like Pfizer and Moderna is. And we really want people that had J&J initially, that are 18 years of age or older, to get that shot 2 months after their second shot. So that was the booster recommendation. So those people should be getting boosters. The other recommendation that they came out was something called heterologous vaccination. So this is mix and match strategies. And so what they said is that booster you get, either that second shot of J&J or the third shot after your Pfizer or Moderna, could be any vaccine. So it could be J&J, could be Pfizer, could be Moderna. Really what this does is it's a recommendation to allow convenience of boosting across the general public. And so people don't have to go out and hunt down for a Moderna shot or a Pfizer shot. If they are in a setting where they don't have Pfizer shots available and they had Pfizer initially, they can go out and get a Moderna shot or a J&J shot. So it really offers some flexibility to be able to get these boosters and make it really easy on the public. As it stands right now, we're still recommending people that can get their original series to get their booster shot to match their original series, if that's available to you. So if you had a Pfizer vaccine series and you are able to get a Pfizer booster, go ahead and do that. Same thing with Moderna, same thing with J&J. In those people that can't, and they can't find a booster to match their primary series, then it's okay to go ahead and mix and match, and we're absolutely okay with that. There are going to be some clinical situations where we may encourage people to steer away from their original vaccine series and get an alternative vaccine as their booster. An example would be if an individual developed the rare complication of myocarditis after getting a Moderna second shot. Well, that person I would recommend to get a J&J booster. Those are, very rare instances, and we'd really encourage people to talk to their providers, their clinicians, in terms of what's right for them. But the vast majority of people in Utah, given the accessibilities of the vaccine, should get a booster that matches their primary series. And if you have any questions about what's best for you, I'd say please reach out to your primary care provider and have that discussion.
A question for Dr. Stidham. Is there a concern about having too many antibodies? Can that overload your system?
No, not in the setting of vaccination. We know that our antibody levels wane over time. That's normal. That's what happens after an acute illness or an exposure to vaccination. And what a booster does is it brings them back up to those levels that we saw after the original series. And so at this point, there's no concern about too high of antibody levels.
And an additional question, Dr. Stenin, have you seen that people are who are eligible for boosters are getting them, or are you hearing anything about people being cautious about moving to this next booster step?
No, my colleagues that I talk to in the hospital that are taking care of patients with COVID-19, I would say almost universally, they've all been boosted, and they fall into that healthcare worker category. And we've not had any concern in our healthcare providers that we're worried about that third shot.
Okay, and one additional question, just to clarify, if it's okay to mix and match, why would a recommendation then be to get the same series if possible? What's just a clarification there?
Great question. Right now, the data on the effectiveness of boosters is very early. We know that a boosted shot of Pfizer significantly improves your protection against infection. We know the same thing with J&J. The studies about looking at the effectiveness of a boosting strategy in clinical real-world data is pretty minimal. And so we are certainly more comfortable with the boosting of using that using a booster that matches the primary series because we know that data. We're going to be certainly following very closely the effectiveness of a boosting strategy. And if we see that one strategy is more effective than another, then we'd make that recommendation. But as of right now, the data that we have suggests that getting boosted with the same that you received in your primary series is probably the best way to go initially. And we'll obviously be following this data really closely to make recommendations moving forward.
Dr. Prince, a question from you from Chris Reed at the St. George News. He said, I had a public official tell me last week that they visited a friend with a different ailment at the St. George Hospital ICU, and while crowded, he didn't feel it was as crowded as he thought it would be. Does that correlate with experience of you and the other physicians there in St. George? I guess he's wanting kind of a sense of, what is crowded and what's not.
Right. So we're not in the business of putting in so many patients that we can't take care of them. We want to make sure that our nursing staff is comfortable with the nurse to patient ratio. Now in the ICU, that might be 1-to-1 at times, it might be 1-to-3 or 1-to-4 at times. We don't want to overload those nurses to the point where they can't perform their job and perform it safely. Many times we have a nursing shortage. So our capacity in the hospital is many times limited based on the staff that we have to provide care, not necessarily beds that we have. So you could come in the hospital at any given time and you may see empty beds. That's not because we have a bed shortage, it's because we have a nursing shortage. And, like I said before, they're burnt out. They don't want to provide poor care. They don't want to have a patient die because of a mistake they made. So we haven't been overloading them. We've been sharing some of the burden with other resources. Intermountain Healthcare will transfer some to Utah Valley, or will hold on transfers into this facility to try and manage that workload.
Thank you. Dr. Bergeson, what would you share with the community based on your experience with the high volumes in the COVID situation in Provo?
Well, first of all, I would say that, the hospital administration and the staff are fully committed to caring for these patients that are critically ill. And we've been lucky here that our staffing has been at a high level. We don't have unstaffed beds, essentially. And so we're able to be flexible with that, that demand. So I think our desire is to be a reliable community partner here. And I think we've been able to fulfill our part of our commitment in that regard. I would like people to know as well that we are doing everything we can to provide as much surgical care as we can. And I think it's important to recognize the difficulty of some of these decisions. We were recently reminded there was a COVID patient that was unvaccinated that required care at our facility for several weeks over the summer. His story was highlighted in the New York Times And really their plea was for vaccination, and that they were kind of regretting that decision. He was able to get better and leave the hospital. And he and his wife recently put out a video. His name is Russell Green, his wife Mindy, kind of thanking the staff, thanking the surgeons, thanking everyone for the care provided, but also, highlighting how thankful they are that he's able to continue with the life that he loves. And I think it's a reminder to all of us, and very inspirational to me personally and to others that I know too, that we are committed to providing the care needed for these critically ill patients. And it's worth sacrificing for these individuals. And the conflict comes in that there are other individuals in our community that are suffering from these conditions that are not life-threatening, are not as urgent, that require surgical care, and we're just not able to provide that care right now. So at least to the number of patients that we would like. We're still trying to prioritize, and those that are more urgent, we are trying to take care of. But there was a situation this last week where we had to postpone a brain tumor surgery for a day or two in order to have an ICU bed to take care of that patient postoperatively. So we are facing those decisions daily. Those decisions are real, and there's individuals behind each of those decisions. And we acknowledge that, and we're doing our best to extend our capacity to provide staffing. We're bringing in reinforcements. We're hiring traveling providers, and hopefully with that effort and with a sustained community health effort to vaccinate as many as possible, we'll be able to emerge from this soon. But some uncertainty remains, and we're committed to being a reliable community partner through that uncertainty. So.
Thank you. Just a couple questions, Dr. Sidnam. If you have a family gathering and some of the folks who are not vaccinated refuse to wear a mask, what do you suggest? That's a question from a reporter.
Yeah, so there's a number of options. You could say, then you can't come. I mean, that's the extreme option, is you can keep your family gathering to those that are vaccinated. You also have to really think about what is the risk of potential transmission among your family. If you have a grandmother who's vaccinated and is 85 and has underlying comorbidities, the risk to that person of giving COVID-19 is really, really high. And so you really have to assess, what is the risk of my family in contracting COVID-19 from somebody who's either vaccinated or unvaccinated. The other thing you can do is you can require testing before people come into your home for a family gathering. And so you could do that in any number of ways. There are testing facilities all over the state, and you can say, I'd like to see a negative test within 48 hours of coming into my home to minimize that risk of that person coming in with asymptomatic COVID-19. And if they have a negative test, then okay, you can come in and enjoy the holiday. And absolutely, by all means, say if anybody is symptomatic with a respiratory illness, that's a non-starter. They should not be joining the family gathering for that. So I think you have some options. Testing pre kind of party is a good option. Really encouraging, obviously, vaccination. And then really assess what is the risk to your family members in that party.
The recommendation for the Moderna booster has been a half dose. Is that significant? And is that a sign that the Moderna has been working better than the Pfizer or J&J? What does that half dose represent, as the others are full doses, it appears?
Right. So let's take that last question first. When we look at the waning effectiveness of the vaccine, you compare Pfizer to Moderna, it looks like Pfizer has been waning a little bit more than Moderna has. Moderna still shows some evidence of waning, but the vaccine effectiveness is in general higher than that of Pfizer. Why that is, we're not really certain. The primary series of Moderna is 100 micrograms of messenger RNA compared to 30 micrograms in the Pfizer. And so it's a higher dose. And so that potentially is the reason why Moderna is holding up longer. In addition, Moderna is given 4 weeks apart instead of 3 weeks apart in the Pfizer vaccine. And that is another potential reason why it's holding up a bit better. And so which is looking better. Moderna has a little bit of an edge, statistically speaking, in terms of waning, in terms of vaccine effectiveness. But both of them get back up to those high levels with a booster shot. So the 50 micrograms, that's the half dose of the Moderna shot. This is what was studied, and it definitely is enough to get you back up to those antibody levels that you had after the initial series.
And one last question before we finish, Dr. Stidham. For somebody who's out there considering, who's still unvaccinated, we typically end these calls with what your advice would be to somebody who is still kind of on the fence. What would you say?
Yeah, I'd say, we're in a very different time right now compared to where we were last March and April. Last March and April, these vaccines had just come out. We had a handful of studies with 40,000 people in each one. They were new vaccines. Our experience wasn't, significant. And so I could understand why people were hesitant at that time to say, gosh, I'd really like to see more data. Now, fast forward to October, and now we can say these vaccines have been so heavily studied, so heavily scrutinized from a safety and efficacy standpoint. These are likely the best studied vaccines that we have in the world. And so we're at a very different place in the amount of data that we have for these vaccines. We know the safety profile. We know the side effects that come with these vaccines. And we can feel very comfortable being able to talk to what are going to be the side effects of the vaccines, what are the very rare potential adverse events that typically occur in the first 2 months after the vaccination. So we're in a much different place. We have so much data on safety and efficacy that we can absolutely stand behind and say that this is a safe vaccine and this is an effective vaccine. So I'd say now's the time. Now's the time to say, let me reevaluate this and let me go get vaccinated because we have so much data on these vaccines. And no judgment. People understand that a lot of people needed more time to really weigh the risks and the benefit of this vaccine. But just know that we're at a very different spot in the fact that we have so much data on this that we can very confidently say that this is a safe and effective vaccine, and it prevents death. It prevents suffering, and it also keeps our communities and our hospitals safe. So I'd say, reevaluate, talk to your clinicians, and now's the time to get vaccinated.
Well, thank you, Dr. Stidham, Dr. Ferguson, Dr. Prince, thank you for taking time. We know you're very busy and we appreciate you providing this update to the communities. Thank you for the service that you provide and all that you're doing along with your colleagues. We would recommend that if people want to learn more information about vaccinations, that we invite them to go to the state's COVID website at coronavirus.utah.gov, or they can also go to the Intermountain website to learn more about testing and COVID services at intermountainhealthcare.org/COVID. Again, thank you all for joining us. Appreciate it. Have a good day.
Thanks, Jess.
Thanks, everybody.